No, my pleasure. Well, hi, everybody. It's a pleasure to have a chance to talk with you again. A little while ago, we talked about supraventricular arrhythmias. Today, we have a few objectives to turn our attention to the bottom chambers of the heart, the ventricles. So we want to recognize the clinical presentation of sudden cardiac death and its public health impact. And that association is very important because ventricular arrhythmias should trigger in your minds as a first reaction concern for sudden cardiac death, because our major concern in medicine is always to focus on things that are most dangerous first, associations that are most dangerous first, and then worry or can be concerned or address things or conditions that are less significant. And on the subject of ventricular arrhythmias, sudden death is top on our list for worry. We want to recall the role of ICD therapy in the prevention of sudden cardiac death and recognize the indications for cardiac resynchronization therapy and its clinical effectiveness. So again, like we talked about before, we're here to practice medicine as both an art and a science, and ultimately a way to take care of human beings. So I want to share with you an unfortunate story. A 69-year-old academic cardiologist, no documented cardiac history. He taught me, he taught others cardiology and medicine, and was a great guy. Non-smoker, non-diabetic, mild hypertension. He was an avid bicyclist, and he actually used to bicycle to work. He exercised regularly, robust. He practiced what he preached, lived an active life. This is just a quick picture of him. Unfortunately, he didn't show up to work one day. Nobody knew where he was. Somebody had the good idea of tracking his bicycle route, and they indeed found him on the side of the road in his bicycle, feet still clipped in the pedals, slumped over, actually dead, unfortunately. And that presentation is a very classic one for what we call sudden cardiac death. When he underwent autopsy, he had a slightly enlarged heart. There was coronary atherosclerosis present, but no infarct. So that was not a heart attack that killed him. And what in fact was found, unfortunately, is here's a cardiologist who's teaching people how to recognize symptoms of cardiac disease, and his office drawers, when they were being cleaned out by his family, were filled with antacids. So this poor guy, who was an expert in angina, chest pain, working up cardiac disease, was having very likely angina himself and treating that angina with antacids, thinking that it was all heartburn, when in fact it wasn't. So what he experienced was sudden cardiac death. That presentation is defined as unexpected death due to a cardiac cause that involves abrupt loss of consciousness within an hour of the onset of acute symptoms. That's when a patient or an individual is able to be witnessed, or if it's unwitnessed, death within 24 hours of being last known alive and asymptomatic. And that's what was the case in this individual. So he was a sudden cardiac death victim while bicycling to work. That episode, that phenomenon, happens about 1 time per 1,000 population per year in the United States and Western Europe. And that translates to a lot of people. That's 350,000 cases a year in the West. In Japan, it may actually be a little bit more. There was a single county study done a number of years ago that looked in Oregon, and the actual number, when every single death was adjudicated in that county, was around half a sudden cardiac death per 1,000 population. If you look at all-cause deaths, about 60 million people in years past. These numbers are higher now. Non-communicable diseases are about 2/3 of those deaths. Cardiovascular disease is about 1/3, and sudden death is a very significant cause of death. And that phenomenon of dying suddenly is largely attributable to a ventricular arrhythmia. And what's interesting is that it can be a reversible phenomenon. That's why we actually associate a survival rate with sudden death. It sounds like it's a contradiction. Death, surviving death, what does that mean? Well, in the case of a malignant arrhythmia, if that arrhythmia is reversed in time before the body suffers irreversible death, it can be survivable. So in the United States, that episode that the poor doctor had, who was unwitnessed at the time and had no way of having anybody resuscitate him, actually can be survived about 5% of the time. 95% of people don't survive, about 1 in 20 people do. Elsewhere in the world, of course, because EMS isn't anywhere nearly as robust as it is in America, the survival rates are much, much lower. Western Europe is somewhere in between. We think about 3/4 of these cases are due to primary ventricular tachycardia or ventricular fibrillation, which are the archetypical wide complex tachycardias or ventricular arrhythmias. This is how sudden death stacks up to other major killers. It's a big deal, and it happens a lot. And one of our primary goals in medicine and cardiology and cardiac electrophysiology is recognizing it and certainly treating it when it happens in front of us and trying to prevent it so it doesn't happen when we're not there to respond. A couple of clinical pearls. 80% of sudden deaths occur in the home. That probably reflects the fact that people spend a fair amount of time at home, particularly at night and in the early morning. But 60% of them are witnessed. The highest risk day when you look at these episodes in terms of time is Monday. The highest risk time is early morning. The highest risk season is winter. And men who are middle-aged actually have a 4 times greater likelihood of having an event that results in sudden death than age-matched women. Let's talk about how this happens. So you've seen this before, perhaps from the previous lecture. This is just a review of what the heart looks like. Beautiful organ, 4 chambers, 2 atria, 2 ventricles. That's the pump that circulates blood through our bodies and keeps us alive from the time we're about 10 weeks old in our mother's wombs until the last breath we take. And that beautiful choreography of heart pumping where the atria squeeze blood into the ventricles, which then expel blood from the heart, is controlled electrically. And the electrical wave originates in the sinus node and the high right atrium, travels to the AV node, then gets propagated through the ventricles. And everywhere that electrical wave travels will contract. So the atria contract, pushing blood into the ventricles, which then contract, pushing blood out of the heart. Very nicely organized. And that's normal heart rhythm. Now, what's interesting is that in ventricular fibrillation, that is a wide complex tachycardia that can result from acute coronary ischemia. So if somebody's having an active infarct, one of the first things that can happen is because of blood flow limitation to the muscle, there can be electrical derangement of heart muscle conduction. This is what VF looks like on a rhythm strip or a monitor. It's no organized activity at all. It almost looks like it's artifact. The most common etiology for ventricular tachycardia, which is the other classic sudden death inducing ventricular arrhythmia or wide complex tachycardia, is myocardial scar, an actual fixed circumscribed scar in the ventricle, which can be the result of a prior infarct, death of heart muscle tissue and its replacement by dense scar, or muscle toxicity due to chemotherapy drugs, longstanding hypertension, a viral infection, a host of other causes, but the net result being scar tissue in the heart, resulting in a more organized wide complex tachycardia. But the result can be very similar, which is hemodynamic collapse and syncope, and if not treated or reversed, sudden death that becomes irreversible permanent death. There are also heritable causes of this phenomenon that result in wide complex tachycardias or ventricular arrhythmias. Long QT syndrome being at the top of the list, an inherited disorder that's a channel mutation. Short QT syndrome, an even rarer condition that results in the same phenomenon. Hypertrophic cardiomyopathy is another genetic cause of this, familial dilated cardiomyopathy. Some of you have heard of Brugada syndrome, which is a rare but still occasionally seen channelopathy, so inherited disorder of ion channels that can result in a wide complex tachycardia and sudden death. A phenomenon known as catecholaminergic polymorphic ventricular tachycardia, or CPVT. This is a VT that develops in an otherwise structurally normal heart, often during exercise, and it's brought out during exercise, and we can bring it out with stress testing. There's another rare condition called arrhythmogenic right ventricular cardiomyopathy, or ARVC, which also results in genetically based rearrangement of muscle tissue and replacement with fat that creates an obstacle to electrical flow and potentially ventricular tachycardia. So let's look at this in graphic form because there are similar principles that underlie all of this. When the heart muscle is normal, remember how we talked about this before, it's like a highway that is allowing traffic to proceed down its beautifully paved asphalt all at the same speed. And that's the way the heartbeat should normally be governed, by an electrical wave that travels through the atria and ventricles at the same speed everywhere. So all the traffic stays in its respective lane and things are happy. When there's an area of the heart that is not conducting electricity normally, that's when problems can arise. So this is an example of acute injury. So if somebody has acute coronary ischemia, let's say a left anterior descending occlusion that results in an area of heart muscle tissue in the anterior wall becoming less filled with blood, less healthy, less able to conduct electricity normally because the area of muscle is starting to get injured, doesn't conduct electricity as well. What can happen is a series of biochemical phenomena, such as leakage of intracellular potassium, depolarization of the myocytes locally because of that potassium, and most importantly, this concept of heterogeneity of conduction and refractoriness. Simply put, asphalt that's no longer nicely paved and able to handle cars at the same speed. Now this area of the highway is not allowing traffic to proceed as fast. And so there's fast traffic next to slow traffic. That's heterogeneity of speed. And what can end up happening is what we call reentry. Reentry at the periphery of the scars and reentry within the scar if there's muscle that conducts in it, or potentially one big circuit going around the whole scar if no conduction's happening in the middle. But you get the point. It's like a big pothole in the middle of the highway that cars have to avoid, and they avoid it by swerving.
You mind not moving so much?
Excuse me? Oh, is that a question? Sorry. Anyway, we'll keep on going. This is just showing you what happens in the case of a dense scar, this phenomenon in an animated form here, a dense scar that allows re-entry to occur around the whole thing. So that's a classic representation of a ventricular tachycardia due to re-entry around the scar. So if scar tissue or changes to the heart muscle's health, the integrity of the heart muscle, most importantly, its homogeneity as an electrically conductive organ or surface or road, is the reason for ventricular arrhythmia, it's not surprising that we recognize that the most important predictor of sudden cardiac death and overall mortality that's able to be measured is ejection fraction. So when the ejection fraction is reduced, that increases the rate of sudden cardiac death, increases the rate of ventricular arrhythmia. This is just a cartoon to show you, or a diagram to show you what normal heart muscle can look like. Nice compact heart, thick walls, normal muscle. And then when a heart is failing, what happens is the heart dilates, the muscle dilates, and you've learned this in prior lectures and you've seen this, and the muscle tissue itself thins out. And the net result of this can be a reduction in the overall ejection fraction because the heart muscle itself is now not all homogeneously conducting electricity and not nicely pumping homogeneously strongly, but actually heterogeneously so, because there may be areas of injury, there may be areas of fibrosis, scar tissue, replacement of muscle with fibrous tissue. And the ways that this can happen are numerous. So we talked about the coronary artery disease way, infarction, injury and infarction, but lots of other things can cause scarring of the heart and replacement of normal myocardium with either unhealthy myocardium or scar tissue. Volume and pressure overload can do this acutely and chronically. Connective tissue diseases, primary cardiomyopathies, including the heritable ones we talked about. Other diseases, drugs are a classic. At Georgetown, we see a lot of cardiomyopathy and ventricular arrhythmia due to scar tissue in the heart due to chemotherapy drugs from our Lombardi patients. Infections can do this, so myocarditis is an issue. And in particular, in the era of COVID, many of you have heard of COVID-related myocarditis. So we're starting to see scar tissue, cardiomyopathy, myocarditis due to COVID, and interestingly, even arrhythmia, ventricular arrhythmia in certain COVID cases. Not common, but we're seeing it. Other conditions as well are listed here, and the big elephant in the room, of course, is coronary artery disease, which is probably the single largest contributor to LV dysfunction in the Western world. This is just a diagram that shows you how, as the ejection fraction decreases, the likelihood of death of all cause and arrhythmic death increases as well. So the lower the ejection fraction, the higher the risk of death. There's a nice inverse relationship between the two. And what's interesting in people with coronary artery disease is there can be a long time that can pass between the creation of the scar, for instance, in the case of coronary disease, the myocardial infarct when the heart muscle is killed, and the sudden death event. Yes, it can occur acutely. In the course of the ischemia and the infarct formation, there can be enough heterogeneity of conduction and enough substrate and just the right timing that an arrhythmia can occur. Or it can be a ticking time bomb, sort of a pothole in the highway that at some point down the road can lead to an accident, can lead to the circulating rhythm that causes a sudden death event. And In one particular study, that interval between the two events, formation of scar and sudden death, was 6.5 years. This is another European study that showed that in people who suffered cardiac arrest, and a whole series of about over 200 of them, only 4% were due to an active acute MI, active injury at the time. The majority were due to prior injury or prior scar tissue that had been there just as a ticking time bomb. And the median time in this study from the MI to the sudden death event was actually 9 years. Very interesting. So it just goes to show you that once scar tissue is placed there, the problem or the risk actually is there long term. Because as you know, heart muscle doesn't regenerate. It's not like skin. It's not like liver tissue. If any of you in the room or listening can come up with a way that heart muscle tissue can regenerate after an infarct or injury, you'd probably win 10 Nobel Prizes, not even one, because this is kind of the holy grail of cardiology. How can we get injured or diseased or dysfunctional heart muscle tissue to be replaced by healthy tissue? This is just yet another example of how cardiac mortality can occur long after the original MI or the original scar tissue, and it can be much later. This concept of heart failure is something you know about already. It's one of the leading diagnoses that we deal with in medical care worldwide, especially in the United States. Something like 500,000 new cases a year that get added to a prevalence pool of 5 or more million people. 250,000 drop out because they die, but it's actually a source of major healthcare resource consumption because more than 1 million hospitalizations a year are due to heart failure. These numbers continue to grow. What's interesting is that if you look at people with heart failure, remember, heart failure is defined as a heart that is not squeezing strongly enough to meet the body's needs. We generally associate heart failure with reduced ejection fraction, but there can be heart failure in patients with preserved ejection fraction. For the purpose of our presentation here, we're going to focus on reduced ejection fraction patients. These are people who are symptomatic, their hearts don't squeeze as well. What's interesting is if they've managed to make it to the point of class 4 heart failure, which is really sick hearts, they're often on drugs just to keep them alive and breathing. When those patients die, if you look at the cause of death in that category, the main cause of death in these people is actual pump failure death. The pumps fail and the patients suffer that awful pulmonary edema, congestive death. About a third of those patients die suddenly because of a ventricular arrhythmia. If you look at the other extreme, people who have milder degrees of clinical heart failure, but still, remember, scar tissue in the heart, ticking time bomb, potential arrhythmic substrate, and you look at the reasons for their death, they're actually more active, ambulatory. They look better because they're not as clinically sick from their heart failure pumping dysfunction. The primary reason these people collapse and die when they do die is because of sudden death, and heart failure, pump failure death is less common. So it's an interesting almost paradox that the better people may look clinically, but with low ejection fraction, the higher likelihood they have of having a sudden death event. We use pharmacologic therapy for these people to help their symptoms, but pharmacologic therapy does not reduce mortality, does not reduce the likelihood of sudden death due to a ventricular arrhythmia. There's only one therapy that has been shown to do that in these patients, and that's described in the following story. It's an implantable cardioverter defibrillator. And there's a reason that I want to show you this picture, because it's a story that is very worth sharing. So, Dr. Murawski, as you see here, was a cardiologist, worked in Baltimore. He had a mentor, not unlike my mentor, one of my professor of mine who died suddenly while on a bike. Well, this is what happened to his mentor. You might think there's an outbreak of this in Baltimore, but it happens all over the world. So many years before my poor professor died, he was at the home of his mentor who had invited him for dinner with his family. And at the dinner table, his mentor actually collapsed right there and died in front of him, in front of his own family. And of course, Dr. Murawski knew what that was. He knew it was sudden death because there was a sudden loss of consciousness, sudden loss of blood pressure, and collapse. And it had been known for decades that that's very likely due to an electrical chaos, ventricular arrhythmia, that could be shocked and restored, and having circulation restored due to restoration of normal rhythm with an electric current that's delivered to the heart. But of course, defibrillators weren't around then. It was an experimental tool in hospitals at the time. So Dr. Murawski went into a lab and came up with the idea that if he could create a device that could be implanted in the body and could recognize when that sudden death event, when that ventricular arrhythmia might happen, he could save a life with a device that could recognize the event and then deliver an electric shock in response. So he put this prototype together. Now here's where the story gets kind of interesting, but almost tragic, but luckily wasn't. And it's a good lesson for all of us. He presented it to faculty at Johns Hopkins, and he let them know this was his prototype, this was his idea, this was his device, and then he was interested in starting a clinical trial. Now, you might think that something so revolutionary and interesting and sensible like this would gain a lot of traction and get a lot of positive feedback, but instead, just the opposite happened. The people basically to whom he presented basically laughed him off the stage and said, this is not a good idea, this is absurd, this is just crazy science, not even science, go back to the lab and do something much more worthwhile, like molecular biology, this is ridiculous. Can you believe that? Now, good for Dr. Morawski. He so believed in what he was doing, perhaps in part motivated by seeing it firsthand and having a personal connection, that he stuck it out, developed a prototype ready for human trials, and the very first clinical defibrillator was actually implanted at Johns Hopkins in 1980 by Levi Watkins, who was a cardiac surgeon. And in the early days of defibrillator therapy, because it was shown to be an effective tool, do you know how you could get a defibrillator, what the criteria were clinically to get it? You had to have had a sudden cardiac death event, so ventricular arrhythmia collapse, and then miraculously or fortunately, fortuitously, whatever, have been resuscitated because of bystanders doing CPR or defibrillation or whatever. And then you had to have another sudden death event and survive that one, and then you'd get a defibrillator. Isn't that interesting? So 2 sudden death events, as we know now in today's world, each of those events carries a 95% likelihood of unrecoverable death. You have to suffer that twice and then you get a defibrillator. If you're so lucky like that, you probably wouldn't need a defibrillator. You're like immortal. Nothing would happen to you. You get run over by a truck and spring back. That's what we joke about today. But that's the nature of medicine at the time. There was rationing of a very scarce resource, but it's a very important story. Of course, the field has evolved. Now we implant defibrillators much, much more widespread. They're not implanted by surgeons. They're implanted by cardiac electrophysiologists. And any of you who'd like to see this, you're welcome to come watch these get placed. They're in the hospital, done in the hospital on the 4th floor in the cardiac laboratories there. The devices are much smaller. They're placed under the collarbone with a wire that gets threaded through the subclavian vein into the superior vena cava and rests within generally the right ventricular apex or right ventricular interventricular septum. And these devices, through that wire, which acts as eyes and ears in the heart, watching the heart like a sentinel 24/7, when you're sleeping, when you're awake, when you're on your bike, when you're at work, when you're at rest, whatever, can recognize a ventricular arrhythmia, send the signal to the computer and the device to say, ventricular arrhythmia detected, cross-check, make sure it's sustained, make sure we're not being fooled by sinus tachycardia or AFib or something else. And if there's a confirmation algorithm that's all said, yes, 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 this is a ventricular arrhythmia, an impulse is delivered to the heart to shock the heart out of that arrhythmia and restore normal rhythm. Or in a more sophisticated way, what often many devices have as a prelude to a shock is actually the ability to rapidly pace the heart to overtake the ventricular tachycardia. We call that antitachycardia pacing. If the clinical tachycardia is causing the ventricles to quiver at 180 beats a minute, for instance, the device can recognize that, and the defibrillator can pace the heart at 190 or 200 beats a minute just for a few seconds to overtake the circuit and then stop pacing, and the heart resets and normal sinus rhythm is restored. So antitachycardia pacing first, 1, 2, or 3 cycles, whatever you can program, whatever you'd like to program with the parameters that you want to set, followed by a shock. That's typically how we program defibrillators. That's how they work. How are we implanting them? Well, it's interesting that originally, remember, 2 sudden deaths, you survive both, you get a defibrillator. Then 1 sudden death, and you get a defibrillator, because clinical trials supported the notion that having a sudden death event put you at very high risk for having a subsequent sudden death event. That's a classic phenomenon in medicine. If you have something once, you're likely to have it again. If you've had an MI once, you're likely to have it again. So you need extra attention in therapy. If you've had sudden death once, you're likely to have it again. This is an example. So the early days of defibrillator therapy were what we called secondary prevention. You had a primary event, you got a defibrillator to prevent a secondary sudden death event. And as time evolved, the question became, well, that's all well and good. You're saving people who survived a sudden death event, but we know that only 5% of people survive it. So you're only dealing with that 5% population. What about the 95% of people that had an event before you recognized it? How can we protect them? How can we affect primary prevention, preventing the first or primary sudden death event? And that's where a revolutionary trial that's almost 20 years old now came about, which was called the Made It 2 trial, a multi-center automated defibrillator implantation trial. This looked at a very simple population. People who had coronary artery disease, had a low ejection fraction, no necessary history of VT or sudden death or anything at all. They were happy-go-lucky, managed on their medicines, and they were randomized to two groups. One group that was on optimal medical therapy, the beta blocker, diuretic as they needed, and angiotensin angiotensin converting enzyme inhibitor therapy to reduce afterload, etc., appropriate drugs to treat their coronary artery disease and or heart failure, versus that plus a defibrillator. So it was a pure randomized trial of the effectiveness of a defibrillator in people who are optimally medically managed. And the idea was maybe defibrillators implanted in this population that we know is higher risk because they have lower ejection fractions, maybe a prophylactic defibrillator could save life. And the idea was to follow people over the course of 5 years and then make some determinations. What was very interesting is that at year 2, the Data Safety Monitoring Board that follows clinical trial patients through the course of the trials to determine if the trial is safe or dangerous, ethical, not ethical, said that they unblinded the results because they said it would be unethical to continue this trial as we progressed because people in the defibrillator arm were surviving at a greater rate than people in the just medical therapy arm. There was a 31% mortality reduction at year 2 in people who received defibrillators versus those who didn't. That was very substantial. And when these data were looked at over the long period of time, because not everybody elected to just get a defibrillator, even though the study suggested they should, there are data extending out to 10 years of follow-up showing a divergence in survival. So red means means mortality, and blue in the arm with the drugs, this is the mortality arm of patients who just got drugs alone. Blue are the patients who received a defibrillator, and you notice how their survival curves continue to diverge over time. So if you will, a defibrillator is the gift that keeps on giving, and not surprising because once that scar tissue is present, once the low ejection fraction reflecting scar tissue is there, it's a constant potential substrate for a ventricular arrhythmia event that could cause sudden death down the road. A defibrillator is therefore therapy that protects these people long term. And that's why people with low ejection fractions and coronary disease history now qualify for defibrillators. And that's a benefit that cuts across age, heart failure severity, ejection fraction, gender, etc. It's very, very important that we know that. Then attention turned to people without coronary artery disease, so not artery blockage disease, but cardiomyopathy, therefore scar tissue in the ventricles due to other causes, the non-ischemic cardiomyopathies, things we talked about, like the Georgetown patients with chemotherapy-induced cardiac pathology, etc., other conditions like that. And this was a trial known as SCD-HeFT, or Sudden Cardiac Death and Heart Failure trial, which looked at 2,500 patients with heart failure and low ejection fraction, and it was a grab bag, a mix of both ischemic and non-ischemic, all comers. And they were randomized to not just 2 arms, but actually 3 arms, because this time optimal medical therapy was in one arm, optimal medical therapy plus a defibrillator was in another arm, and optimal medical therapy plus amiodarone was put in a third arm. Amiodarone has been recognized for decades as a ventricular tachycardia reducing drug. It actually calms the ventricles down when they're irritable and tachycardic or fibrillating. And it has been shown, it was shown ages ago, decades ago, to be effective at suppressing ventricular tachycardia. So the idea was, why do you have to give these people an expensive defibrillator? You can just give them a cheap drug and they would still have the ability to get better and potentially be protected. So that was an arm of the study. And in order to control against the pill, the amiodarone pill, a placebo arm was added as well. So 3 arms to the trial, and look what happened. The amiodarone and placebo survival curves were superimposed. This is a mortality curve, so higher means higher likelihood of dying, lower means lower likelihood of dying. The defibrillator arm, shown in green, showed reduced mortality. So defibrillators save lives in this group of non-ischemics as well as ischemics, and amiodarone didn't help survival one single bit in this big study. So even though it does suppress ventricular arrhythmia in the acute setting, it wasn't an effective protection against sudden death. Defibrillators were. So lots of trials have been done in the decades that followed the defibrillators development in the late 70s, early 80s, and they all come to a very similar conclusion that when used as secondary prevention, defibrillators save life. When used as primary prevention, defibrillators save life. And the benefit is about 30% at 2 years versus conventional therapy. So patients with heart failure symptoms and low ejection fraction live longer with defibrillators than without defibrillators. So if you encounter people with a low ejection fraction that's truly low, not just isolated on one particular echo on a bad day because of whatever, an acute illness, but truly reflecting intrinsic cardiac pathology, they should be considered for cardiac arrhythmia. So please call the cardiology service for an evaluation. So this is just a quick review. Clinical indications for ICD implantation include prior sudden death or documented sustained VT or VF, any inducible ventricular tachycardia on a diagnostic EP study. That's a technical group in people that have clinical histories that are suggestive of ventricular arrhythmia, and we're just not sure. And then people who have low ejection fraction with heart failure symptoms or coronary disease. And I'm just including this in the slides for reference because they come right out of our guidelines, but I won't go through the exact granular details for the exact clinical criteria, conditions, and specifics that have made it into the guidelines and their level of evidence. The simple answer is low ejection fraction that's permanent needs to be considered for a defibrillator. It's a device. It's an invasive procedure to deliver the device. We do this safely, routinely, constantly. It's an outpatient procedure. People come in, get it done, go home if they're an outpatient, or get it before they go home from the hospital as an inpatient. Small risks of procedural injury like pneumothorax, cardiac tamponade because of the lead perforation, etc. It's a foreign body, so device infection is an issue in rare cases, but we do this in a very sterile, infection-controlled environment. And there can be psychological consequences to having an implantable device. Something in you that might shock you is what some patients find anxiety-provoking, and that's of concern. This is just a newspaper clipping because Medicare is very strict about the criteria for implanting defibrillators. They want us to stick to guidelines. So yes, defibrillators are very protective. Yes, defibrillators work well, but they need to be done appropriately. They need to be implanted in the appropriate patients based on guidelines, not in a frivolous way with anybody that you might think could benefit. Really, patients should follow guidelines, meaning low ejection fraction that's permanently low in patients that have been managed optimally medically. Some new developments in recent years have been a subcutaneous version of this. So this is a defibrillator that's implanted under the skin, but instead of a wire going under the subclavian vein, into the subclavian vein and actually resting inside the heart, the detector and the shocking apparatus is actually subcutaneous outside. It's extrathoracic. So the detection and the shocking are all done from outside the heart area. That leaves the heart and vascular system untouched. This is a technique that we often use for people who are on hemodialysis and don't have effective vein access to the heart, or in young people in whom we don't want to mess with their vasculature. There's a niche population for this. So we consider these devices in these unusual patients, small groups of patients, when a traditional defibrillator may not be the best choice. And these are some examples of these kinds of conditions. There's also another kind of defibrillator lead that's very interesting and useful, and that's a single wire that rests in the ventricle to read what's happening in the ventricle and appropriately treat the ventricle in cases of ventricular arrhythmia, but that also has an ability to see and record a rhythm from the atria via poles that are here that are resting in the atrium on the same wire. That allows us to better distinguish, for instance, atrial fibrillation that might result in a ventricular fast rate from ventricular fibrillation. So it improves the specificity of the device at treating ventricular arrhythmias. This is just a very important, very interesting, what we call paradox. And it's known as the Meyerberg paradox, named after the cardiologist from the University of Florida who originally reported it and published it. And it was the following observation. Let's look on the left side of this chart first. Sudden cardiac death, so ventricular arrhythmia resulting in hemodynamic collapse and sudden death. In the general population is very high incidence in high-risk post-MI subgroups. People who've had an active, fresh scar, cardiac electrophysiology derangement of their ventricles, high risk for a ventricular arrhythmia and sudden death. Cardiac arrest survivors, people who've had prior VT, VF, high risk. Low EF patients with heart failure, not necessarily a prior event, are at high risk. This is that whole population of people in whom we placed prophylactic defibrillators. And then if you look at any previous coronary event or just people with risk factors, they become a much larger population pool, and the incidence of sudden death becomes much less and less in that big population. The general adult population is a massive population pool, hundreds of millions of people. The overall incidence of sudden death is actually very low. Now let's turn to the right side of this chart, and that shows you the actual total number of events of sudden death per year. If you look at these groups, because these people represent high-risk groups, but relatively low numbers of overall people, the absolute number of events is relatively small and modest. If you look at the low ejection fraction group, that actually accounts for only about a third of the total number of sudden deaths a year. We know they're at higher risk, and we've studied those people, but even if, for instance, we got a defibrillator in every one of these people and prevented every one of these events, that would still only be protecting about 1/3 of the total number of events, total number of sudden death events that occur in America per year. The vast majority of sudden deaths that occur every year are in people like my professor who died while he was riding his bike. He was never known to have a coronary artery disease condition, never known to have a low ejection fraction. He was healthy. He was a member of the general adult population. How are you going to protect all of these people? You can't design a study, for instance, to randomize children to getting a defibrillator in youth versus not a defibrillator and see who lives longer over the course of their lives. That would be not a reasonable study, but it gives you the point that there is a paradox. The vast majority of sudden deaths occur in people in whom we have no effective screening tool to see how likely they are to have that event down the road. So this is an area of active research and concern so that we can protect people when they need to be protected and not bother people who don't. Now I'm going to wrap up with just a few minutes about what we call lessening heart failure morbidity. So we talked about ventricular arrhythmias and their most critical clinical manifestation, which is ventricular tachycardia, ventricular fibrillation leading to sudden death, and the one effective therapy we have to prevent sudden death, which is ICD therapy. Now we also use defibrillators or ICDs to deal with heart failure and cardiac conduction derangements, because the ICD therapy can improve mortality, but it doesn't affect morbidity. It doesn't affect heart failure progression. Pump failure underlies the morbidity of heart failure, that is low ejection fraction, and it also can contribute to mortality, as we've seen earlier. So if we can slow heart failure progression, we can improve morbidity as well as mortality in people. So let's just go through a few principles. So one of the consequences of a heart that's failing, a ventricle and a heart muscle arrangement that is not normal, it's not conducting electricity normally and or not squeezing normally, are derangements of cardiac conduction, wall motion abnormalities, mitral regurgitation, in particular when the heart muscle starts to dilate and pull apart the leaflets of the mitral valve in particular. And the result of all this can be impaired cardiac filling, impaired cardiac contractility, and a reduction in cardiac output, basically a dysfunctional pump. One of the manifestations can be what we call prolonged AV conduction, which means that the heart muscle doesn't conduct electricity normally, so an impulse takes a longer time to get from the sinus node to the AV node, and that messes up the normal physiology of atrial systole leading to atrial diastole and subsequent ventricular systole. So it limits the filling period of the ventricle and can promote mitral regurgitation. This is showing you the pulse pressure of somebody who has a long period of time between peak atrial systole and the start of ventricular systole. So the time when the blood is pushed into the bottom chambers to the time that the ventricles contract and expel the blood. So that can limit the filling of the ventricle and therefore limit the pulse pressure, limit that expulsion of the heart. Now, if we better synchronize the A and the V contraction, we can maximize that effectiveness of preload, filling the heart and then expelling the blood from the heart. We improve the pulse pressure, improve the ejection of blood, and that improves the physiology of these people simply by controlling the timing of atrial contraction with ventricular contraction. And we can do that via the pacemaking function of both pacemakers and defibrillators. Now, secondly, more importantly, from an overall global health perspective, is ventricular dyssynchrony, when the ventricles, right versus left, don't contract at the same time. That's shown in that cartoon here in the case of left bundle branch block, which results in a much longer period of time that the ventricle on the left side takes to contract versus the right. Why is that a problem? Let's just think of a simple analogy. If I gave you a human heart right now and told you this is like a water balloon, I want you to expel the contents of this water balloon as best you can, most efficiently. What would you do? You would probably put one hand on one side of the ventricles, one on the other side of the ventricles, and squeeze both at the same time. That's the most effective way you'd squeeze blood out of a water balloon. That's the most effective way that blood gets squeezed out of the heart. That's ventricular synchrony, right and left ventricles at the same time. When somebody has left bundle branch block, that's the equivalent of the right side squeezing first, followed by the left side, right, followed by left, a sloshing of the heart. That's not very synchronized, not very effective, and as a result, the ejection fraction can go down. So delayed lateral wall contraction, disorganized ventricular contraction decreases pumping efficiency, and it's manifested on an EKG by a wide QRS, and it's manifested clinically by generally heart failure symptoms, worsening dyspnea on exertion, worsening exercise tolerance, and increased mortality. This is, as you all know, what left bundle branch block looks like on an ECG. Look how the precordial leads show a very wide complex here, showing the long period of time the left ventricle takes to get depolarized. This is just showing you echocardiographic data comparing the two. Normal hearts squeeze very nicely, nice and complete here. A dysfunctional heart that has left bundle branch block is all disorganized, sloshing. Right side first, then left, right, then left, not very organized at all. If you want to look at this in terms of actual animation, this is what normal synchronous contractions look like. The heart, where the atria and the ventricles are beating nicely and in sync, everything is strong and robust, the muscle is nice and thick and normal size, everything is squeezing simultaneously, and we're going to see that exact same contraction sequence in normal give rise to the disorganized, dysfunctional left bundle branch block failing heart, where there's right followed by left contraction, right followed by left. Inefficient. It's just a worsened way for the heart to squeeze blood out. But we can fix this too. And the way we fix this is actually to synchronize the right and the left ventricles contraction by pacing both of them simultaneously. If you will, it's an electrical bypass for left bundle branch block that organizes the ventricular activation sequence, coordinates the septal with the free wall contraction, and it improves pumping efficiency. That sloshing pump is fixed, and now you have both sides squeezing simultaneously. The way we actually do this mechanically is by delivering a wire, a pacing wire, to the left side of the heart, and we can't put a wire safely inside the ventricle like we do on the right ventricle. The reason being that in the right ventricle, if a blood clot, a little blood clot forms on the end of this wire because it's a mechanical object in the blood pool, where will that blood clot go? It'll go into the pulmonary arteries, into the lungs, and get lodged somewhere, a small pulmonary embolus, which generally is subclinical and irrelevant clinically. But if we did that in the left ventricle and put a wire in the left ventricle, a blood clot has no filter, no lungs to filter it. It might go directly to the brain and cause a stroke. So we get around that by actually putting a wire into the coronary sinus, which is, is the big vein that drains the heart, and we can thread it backwards in the venous system to a narrow origination vessel, vein, somewhere in the left ventricle on the left side there. We place the vein, the wire inside the vein there, and now we're able to pace both sides of the heart, because this side gets paced by the wire that we put in the left ventricle. This side gets paced by the traditional pacing or defibrillating wire placed in the right ventricle, and both sides of the left ventricle squeeze simultaneously, resulting in biventricular pacing. Now, what was very interesting is that early on, people were wondering, well, what does this do to energy consumption? Because one of the problems people noticed is that if you take a failing heart and give it inotropes or give it drugs to improve its squeeze, it's kind of like whipping a horse. So the heart is energy starved, it's trying to get up a mountain, and if you give it inotropes, you're just whipping a weak heart and consuming more energy. And this has been shown to, over the longer run, increase mortality. In the short run, it might help the heart squeeze a little bit better, but you're going to fatigue, get tired out, and increase mortality. So drugs that increase systolic function typically increase energetic demand and have adverse chronic outcomes. What was interesting is when we found out what CRT does. CRT stands for cardiac resynchronization therapy, or biventricular pacing. And what was found is that biventricular pacing, or left ventricular pacing as shown here, actually reduces myocardial oxygen demand, in sharp contrast to dobutamine, which is a drug, a pressor drug, an inotropic drug that improves contraction. So biventricular pacing is a more efficient, more effective way to harness the muscle cells and make for a less oxygen consumptive contraction. So if you look at patients with ventricular conduction delay, it's like the horses are trying to pull the cart up the hill in both directions. They're fighting each other. If you whip the horses, you're just going to exacerbate that dyssynchrony and result in potentially a worse outcome. But if you can use cardiac resynchronization therapy, getting both horses on the same team, meaning aligning the contraction, you can improve the clinical outcome. Lots of clinical studies substantiated this. The bottom line is cardiac resynchronization therapy has been shown to reduce mortality and to relieve morbidity. And we do this in people who have low ejection fractions with heart failure and have evidence of a left bundle branch block. So the left side of the heart is beating later than the right side of the heart. The more exacerbated that left bundle branch block is, the wider the QRS, the greater the benefit when you fix the problem. Right bundle branch block is a little bit different. They have to be really dysynchronous with right bundle branch block to show clinical benefit. Another indication for doing this is if somebody has a low ejection fraction and they receive a traditional pacemaker that has a pacing wire in the right ventricle and they're pacing all the time. So that's what we call an iatrogenic left bundle branch block, right ventricular pacing. So the impulse starts in the right side, depolarizes the right side of the ventricle first, followed by the left side through subsequent conduction from cell to cell. So chronic RV pacing is an indication for us to give people a left ventricular lead or cardiac resynchronization therapy. So I'll summarize all this by reminding us that sudden cardiac death is a major worldwide public health problem. Weakened hearts predispose to sudden death. An ejection fraction of less than 35% is our universally established cutoff, below which defibrillator therapy should be considered, because when added to optimal medical therapy, defibrillators reduce mortality in those subsets of patients that have been studied. In heart failure patients with ventricular dyssynchrony, biventricular ICDs reduce heart failure, morbidity, and mortality. The wider the baseline QRS, the greater the benefit of resynchronization. Up to 30% of cardiac resynchronization therapy patients, however, don't show clinical benefit in the real world. And the results and the reasons for this are probably manifold, but to a large extent, maybe operator dependent. If that wire is not put in the right place to get a contraction on the left side of the heart, like imagine if the wire is put and will pace the heart from the bottom of the left ventricle, then you have a contraction like this. That's not an efficient contraction. Or a wire that's placed in the coronary sinus and it gets to the anterior part of the heart, a contraction like this, that's not helpful. That's the reason some patients don't do well. So it's important that patients get seen and evaluated by somebody who does this all the time so they know exactly where to put the wire properly. And when it's done properly, some people actually show extraordinary clinical benefit with a dramatic increase in their ejection fraction and reduction in their heart failure symptoms. Lead location impacts outcome. Device and lead technology continue to improve. These devices are getting smaller. We're headed toward the day when there's no external outside the heart device at all, but the entire pacing defibrillating system may be actually placed within the heart via a catheter. That'll probably happen early on in your careers in medicine.